We have folks joining us, Dr. Szabo, over. They usually come in over the next few minutes,
Okay.
and we don't push too hard on people coming in promptly because this is just a casual conversation. But we know
Yep.
we respect your time, so we want to make sure that we make good use of it. And we are recording this
Okay.
and be on our platform for people to refer back to. So.
Okay.
More for you because I see a lot of names that I recognize already on the call, and of the 30 registrants, there's a lot of commonality amongst them. But let me introduce you to Practice Habits and what we're doing here because
Hmm.
you're our guest. Practice Habits was created by my team and I here at MJM. Practice Habits is just what it sounds like. We want to practice good habits for the betterment of practice work, right? It's our
Hmm.
version of Atomic Habits, but for the executive practice leader. And being in the Midwest, and I know Elisa can identify with this as well, man, it sometimes feels like when there's new innovations, we're on our own out here. We're kind of at the end of the line with reps. And so if it's going to happen, we gotta figure it out. And a
Right.
lot of people poured into me growing up in this field. And so this is our way of just giving back. Every week we try to have a conversation about a new technology
Hmm.
or an upcoming challenge, maybe reimbursement, maybe team culture,
Hmm.
customer service or otherwise that can give people a leg up on how they lead their teams to do better at adoption and implementation. And so
Okay.
today, I'm happy to have you talking to us about the light adjustable lens. Now, everybody who's on the line, I want to tell you who Dr. Szabo is. So he's only been in practice short of 4 years and is just absolutely taking Central Florida by storm. He's a partner with Dr. Newsom in that area and it just does a lot of light adjustable lens, which we all know is one of the harder lenses to implement because of all the choreography that goes along with it. He and I first met probably just over 2 solid years ago, so he was only a year and a half out of his training, and he was already a super user of the light adjustable lens. But we were together hosting one of the national meetings for RxSight and the light adjustable lens in one of their kind of user group party events in Boston. And it was the Lock It or Love It game show based on um, the dating game, right?
Yep. Yep. I was the Tampa teaser, Matt. That's what they called me, the Tampa
Yeah.
teaser.
And I mean, one, it was awesome. That was a great
Yeah.
time. But two, it was clear to me then, because we hadn't had much exposure to each other, maybe a webinar or two before, but we've co-presented now several times. And Brian is the next big thing in ophthalmology. He's going to be holding down that part of the country for a lot of years to come. And we're excited that you're here with us today to
Thank you,
drop
Matt.
some knowledge with us and maybe just give us a little bit of your background
Yeah.
and Newsom Eye because
Yeah.
you spend a lot of time going from site to site and you're a
Yeah.
leader.
Yeah, so no, thank you so much, Matt, for having me, and to the crew, thanks for having me so much, Matt. I've learned so much from you every time we sit down and have conversations, whether that's over lunch or dinner, or whether we're hosting something together. So can't tell you how much I appreciate our talks.
Well, it looks
Um,
like that's all the time we have today, folks. And
no, but
go ahead.
I won't make his head too big. But no, hi guys, my name is Dr. Brian Szabo. I'm a cataract and refractive surgeon in Tampa Bay, Florida. Originally from Pittsburgh, but did all my training, residency, fellowship down here in St. Pete and Tampa. Growing up in this area, in terms of my training, I got to learn from the best of the best cataract surgeons in the nation, from Hunter Newsom during my fellowship to Rob Weinstock and Neil Desai, and even Pitt Gills at St. Luke's. So very quickly, I became, acquainted with this refractive community here in Tampa, and the standard is just so damn high here with these great, great refractive surgeons. You kind of learn like what it takes and what is necessary to succeed in a market like this. And Dr. Hunter Newsom, over the course of his 20 plus year career, has really positioned himself as like a forefront leader in terms of accepting technologies into his practice, like the light adjustable lens. I think it's what sets our practice apart in this very highly competitive area. And I feel like it's what brought me to his practice was just to learn the adjustable lens, learn who to use it in, who not to use it in, the limits of when you can push and when you can't push. It's one of the things we're really known for the light adjustable lens across the nation. That's how Matt, me, and you got involved together. And it's just a great, great thing to be able to be, an early user, early adopter in a practice like this.
Well, and that's what we're talking about today. I mean, there's a lot of premium IOLs that you have at your fingertips, and they're getting better all the time.
Yep.
The light adjustable lens continues to stand alone in its category. There's from 20 years ago when this category came to be, there was the crystal lens, and then there was restore, resume. There's several variations then on
Yep.
multifocality, astigmatic correction, toricity, etc.
Hmm.
Then there's EDOF lenses, extended depth of field. But adjustability has an important part of the entire segment because of how patients can kind of test drive their
Yep.
vision and fine tune it to their own liking after using it in the
Yes.
world for a few days, and maybe talk about the importance of that category
Yeah.
amongst all of the others.
I mean, with a fixed lens, you get really good results, right? I mean, you get, whatever you're doing with a fixed lens, you're going to hit your target 86 to 87% of your time when you're picking a target for a lens, whether that's a multifocal fixed lens, whether that's a mini mono fixed lens, a straight up distance, we call it custom distance fixed lens. That's 86 to 87% of the time the patient's happy, you hit their target, you're rolling, you never see them again. What about the other 13%? Or what about the patients that really want to hone in? Hey, I'm reading way out here. I want to read here, or, they get to use it in their everyday life and use their hobbies with it because it's very difficult to predict what a patient will like before surgery because they got a damn cataract there blocking their vision, right? So it's very hard to say, like, oh, you're better for this or you're better for that. Wouldn't you want to put a lens in there that you could adjust after the cataract is gone? So they can literally take their vision and play pickleball, play tennis, go play golf, read, go to restaurants, things like that, talk to their friends, and then they can come back and tell you, hey, I need more distance or I need more near vision, and you could change that for them, and then they can go try it again to see if they really like it. I think that little, that adjustability phase, that's the art of this whole, user base of using this lens is the adjustability aspect and giving the patient participation in the entire process, and it really makes it a fun experience.
Well, and so that's the importance of the category, right? The other
Yep.
lenses are good, and like you said, the fixed lens is awesome, especially if you nail it,
Yep.
right? But some of the times there's whether it's because the lens moves in the bag afterwards, effective lens positioning.
Yep.
Not that it moves in the bag, but maybe as it heals, it comes a little forward or it goes a little
Yeah.
back.
It's the only
Um,
variable you can't account for in a calculation. So we can
that's right.
calculate the size of the eye, the shape of the eye, all these different things. You can't account for how the lens is going to sit in the capsule.
Yeah, and by the way I describe it to my girls as they come to my talks and things like that, it's like,
Yeah.
the effective lens position is important. If you've ever used a magnifying glass on a sidewalk as a kid with
Yep.
ants or leaves or what have you, that positioning matters. Well, the
Yep.
same is true with where that lens ends up being in the capsular bag, and it can make
Correct.
all the difference.
Yes.
So now you've found a place for it in your practice.
Mhm.
Um, how do you get your team involved? Because it's not the
Yep.
easiest lens to coordinate around your
It is
office. It's
not.
basically taking everything that you did before surgery
Yeah.
in other patients and doing all that work afterwards, which kind of mucks
Right.
up the system.
It does. I mean, I'm very lucky. I have amazing optometrists that I work with every day in every different location at Newsom Eye I work with. A lot of our optometrists have been residency trained by us, actually. So we have our own optometry residency here at Newsom Eye. So they get a lot of exposure to the LAL and how we do it and the refractions, things like that. You don't necessarily need that in your practice. You could just be a solo MD or DO using this platform. You could have a tech doing refractions. If you have optometrists, they love doing this because it feeds right into what they do. They are very good at using phoropters and all those different things and trying to really hone in what that prescription of the patient, what they like the best. Do they like this prescription for distance or this one for near? And they can really tell where the patient's sitting at. So our process is kind of this. I do the consult, I do the surgery, And then they go to the optometrist for their first adjustment. The optometrist will do a refraction. They'll see like what the patient's expectation is, what they want, and then either myself or the optometrist will actually deliver the light adjustment. Now, that is just how we do it at Newsom Eye. I consult all over the country for RX Sight. Everywhere is very different. Okay. If you have big MDOD practices, a lot of them operate like we do. And I know like what you guys do, Matt, at Vance Thompson Vision. A lot of like smaller practices, though, they just have a tech do the refraction, and then the ophthalmologist can check it real quick. And then they go on and do the adjustment the ophthalmologist does. Or even I know some solo practices where the ophthalmologist does everything from start to finish. It's really process defined by what your practice kind of entails, right? And you can make it whatever you want, but you're totally right, Matt, in saying the art of this whole thing comes in the after, in the post-op, not the before, which is a little bit different of an idea to some people, but it really makes it for a fun, and really, a very creative process. You could do it however you want, however it best fits into your practice to make it the most efficient.
Well, I'm eager to hear your answer to this next thing,
Yeah,
Brian, because because as I told you in Aspen, I have
yeah,
cataract, right?
yeah,
And I don't want everybody on the call to judge me. I'm way too young to have cataracts,
yeah.
but it's
So that
true.
means you're coming to Florida pretty soon, right? You
That's
want to come to
right. Yeah, I'll
Florida?
be
Have
there. I just
Yeah,
have to get my physical exam.
there you go.
Um,
Dr. Newsom will do one. I'll do the second one. We'll have a good time.
the, awesome. So give me the spiel. You're talking to me about
Yeah,
my options.
yeah.
I'm obviously young and extremely athletic. Give me
Yeah.
my options.
So I'm a big proponent of, when you go to see a physician for a surgery, you're going to get an expert opinion. A lot of my colleagues, a lot of my friends, they like to give patients options and then let the patient pick. And that's okay. All right. And we do that to an extent. But if you're coming to Newsom Eye, to myself or Dr. Newsom, you're coming because you're seeking an expert's opinion, and I'm going to give you my recommendation. And when I give a recommendation, I treat you like if you're my mom or my dad. Okay. And Matt, you're too young to be my dad. Okay. It's pretty close. But what I would say is, hey, Matt, if you were my dad, you're my brother, here's what I would use and here's why. Okay. Here's some of your likes, your hobbies. We learn everything about the patient from what they do on a daily basis to what their hobbies are. And then we also kind of look at all their biometry. I have all their topographies. I have their retina. I give a really good dilated exam. And then we talk about what they want to get out of their vision. Okay. So I will look at everything and say, hey, if you want to be spectacle free, here's my advice, here's my recommendation. I would go with the LAL lens. Now, for new users, the biggest home. Oh, sorry. So for new users, the biggest home run kind of thing with an LAL lens is if somebody's used to mini monovision or monovision. So if you're a new person using the LAL, those are your home run patients. Their brain's used to that. Just keep doing it. Set one eye for distance, one eye for near. The patient's going to be ecstatic. The other kind of no-brainer is a post-LASIK, post-RK, or post-refractive, any kind of surgery patient. Those patients, they have kind of wonky calculations. I'm going LAL all day. I am not using a multifocal. Nobody in Newsom Eye will be using a multifocal if you've been touched by a prior laser or prior RK. And then from there, I kind of talk about, hey, we have adjustable lenses, we have fixed lenses. Here's what bucket I think you would fit into, and here's what I would do for your vision.
Okay, so with that in mind, how do you talk about the price then?
So we have something called a refractive coordinator, Matt, that actually goes in and talks to the patient before I even go see them. They kind of get their likes, their dislikes, but they fill out like a questionnaire, and then they'll actually come to me and say, "Hey, this patient, really wants to get out of glasses," or "Hey, this patient, they don't really care about getting out of glasses." And then from there, I'll kind of go in there, and before I even go in there, they have a sheet of our prices in our different categories. We just have A, B, C pricing. Okay, we have our standard lens, then we have our custom distance or toric correction with our multifocal in the same package. So basically, it's like a custom distance, whatever you want for your vision package for a fixed lens. And then our third option is the LAL, is the highest option. So we actually have a physical sheet that has the pricing and all that stuff in there. Now, if a patient asks me about pricing and why it's so expensive, I tell them, hey, you're getting the highest technology that we can offer right now in the world for a refractive cataract surgery because I have the ability to adjust it after. That includes all the visits that it might take to adjust the lens. And on average, it takes like 2 to 3 adjustments, usually around two, and then two lock-ins. That's like 4 weeks of extra work and all that shared time, all that stuff. We also have LASIK built into our package just in case we need to use it as like a late adjustment. So I kind of explained to them why it's that price. And I also explained to them, hey, this is an investment into your vision. For years and years, you've been renting your vision with glasses. Every 6 months, year and a half, you're renting your vision like you would rent a house. Okay. When I do cataract surgery, I'm going to make you own your vision. Okay. And because of that ownership, there is a little bit of an investment into what we're doing for the next 30 years of your life. So that's kind of how I phrase it.
Yeah, I like that. And yeah, that's a nice way to say it and for those who are on the call, we haven't used this analogy here before, but I like to talk about the quartiles of life. There's the 20, first 20, second 20, third 20, and fourth 20 years of life. Those quartiles
Yeah.
is going by the average human lifespan. And it used to
Yeah.
be people got to the end of the third section and they died.
Yeah.
But people are now living that entire extra quartile. I mean, you don't have to go very far to figure that out. It's why our health system is having such a hard time keeping up.
Yeah.
And so it's good to have for that entire amount of your life, for a quarter of your life, to have the hope of spectacle freedom, or at least a reduced dependence on glasses or contact lenses. What a great time of life that would be. So
And I would tell them that too. I mean, there's no pressure on the patient. I mean, you have to do for that patient. We always talk about, hey, what's free and what do you like? If and time wasn't an issue, which lens is best for you? Okay, and with that, there's no pressure on the patients. It's whatever you want to do. I always tell the patients, I work for you. We are a team. I will put in whatever you want me to put in. I want to make you happy and give you the best outcome possible, whether that's an LAL or some other lens as well.
And so, just to be clear, your technician or your counselor talks about the price and the options before you?
We do. That's
What
what we do at Newsom Eye. Yes.
what
We
happens
call
if they say I'm not interested in spending extra?
well, I go in there and I still make my recommendation just like I would regardless. But obviously, if a patient says, "Oh, doc, I can only do what insurance covers," I say, "Nope, no worries, that's fine." You know what I mean? So then I'll talk about, "Hey, you might be missing out on this, or you might be missing out on that. If you're okay with that, then I'm happy to do it for you."
So, one of the things that I like about that is that, and you picked up on
Yeah.
the softball I was throwing you. We still have to educate them on all their options. A lot of people
Yes.
want to do the pre-education or put the price on the website. So they're like, I don't want to do the whole spiel for people who I
Right.
already know won't spend the money, or I'm only going
Right.
to recommend it for people who I think will spend the
Yeah.
money.
I,
Well,
I would say it's
that's
it's
not
hard to.
informed consent.
Yeah, it's not informed consent, and it's very hard to judge that in a person too. I mean, there's been times I walk in there and I'm blown away that they're getting an LAL. Or the opposite happens too, where they're not getting it. I'm like, what? Why wouldn't you get this, technology? I feel like as ophthalmologists, sometimes we judge a little bit. Maybe we look at their insurance and it's not the best, Medicare insurance, and then we kind of just say, oh, they don't want to do anything, or I see what their hobbies are, their job is, they don't want to do anything. People will surprise you, and
Yeah.
people do care about what their vision looks like, after cataract surgery.
Well, and it's why we have to just make sure that no matter what they say coming in, they still have to understand all of their options. And
Right.
so, what we do is we not only educate them by the doctor, but then even in our medical informed consent, we have them sign off. Hey, I know I could correct my astigmatism as part of
Yep.
my surgery, but I'm choosing not to.
I choose not to. Yep. We do the
Right.
same thing, Matt.
So,
Yep.
and the same thing for presbyopia and otherwise.
Yep.
And just on your point about kind of prejudging people, looks can be deceiving. Where we are, there's farmers who walk in who want to pay for all of their insurance with all of their medical work with
Hmm.
cash. They just want to know how much land to sell, right?
Yeah.
Whereas people like me walk in and I can't afford anything, even though I look like this, right?
Yes.
That's a
Yeah.
joke. That's just a joke.
It's been a
Um,
long day. We just got back home from Aspen. It's been long, so I can see what you're saying.
We the other thing I'll just mention, and you know this too because we've talked about it, but it's also why it's important to offer patient financing to every single person. That same counselor should say, listen, it's $5,500 per eye, but
Yep.
most people utilize one of our easy payment options like their HSA plus
Hmm.
care credit or something like
Yep.
that. and just make sure everybody gets that offer, and it'll
Yeah.
help with their adoption.
Yeah, I mean, we use Care Credit all the time, Matt. I know they have interest-free financing up to a year to even 2 years in some instances. So patients use that a lot, and why not? It's free money if you can use it and you want to do it, and that's great.
Now, I just want to ask you a couple more questions, and then I'd like people who are on the line to get ready with their questions because we've got an expert here that we can learn from. And I'd like to know, would you consider the LAL over the last 3.5 years of your career, the dawn of
Mhm.
your career, has it been a practice builder?
Oh, very. So the reason why it's a practice builder, okay? When I do a fixed lens, I'm in a big practice where we're pushing 6,000 cataracts a year, okay? And when I do a cataract surgery and everything goes perfectly fine and we picked a fixed lens, I never get to see that patient again. It's kind of sad. So I only see the patients if the optometrist sends them back to me if there's a problem, right? That I have to go in and fix and make the patient happy. But with an LAL lens, I'm very heavily involved in the aftercare of that lens. And I see the patient almost weekly to sometimes, every 3 days, or even you could do it monthly, however your schedule is. But I get to make a rapport with that patient, which I don't get to do with any other kind of lens. And when you get to make that rapport with the patient, you get to really, they become kind of friends with you and almost like a primary care doctor. You know what I mean? You're seeing that patient routinely, you know their history, you know a little bit about their family and what they like to do. You really in ophthalmology don't get to do that as a refractive surgeon. So it's very nice in terms of meeting people and really get to know you as a person. You get to know them a little bit too. And the more they see you, the more they will talk to you about their friends, to their family. You make that connection with the patient if you're seeing them back and you're doing your own adjustments. So that's why I still like to do probably 80% of my own adjustments because I really and really talk to them, you get to know them, and you should see how many patients I've done that. I'm pushing my fourth year of practice. The friends and family, the brothers, the sisters, the parents, the people are sending me now. I think it's all because of the adjustable lens. Because
Yeah,
otherwise, I'm only seeing that person one time. I never get to see him again if everything goes right, which usually it does in cataract surgery.
yeah.
So it's just such a practice builder. People get to know you, and they also know that you provide the highest of high technology to your community. You know what I mean? You've taken the time to learn this technology. You've taken the time to invest the money in this technology, and that gets out in the community, and people know you're on the cutting edge of technology.
Well, there's a couple of things that I think are really worth noting in what you said. First of all, I love that because it's practice builder because it's just good
Yep.
from a customer experience, right?
Yep.
And it's really patient-driven healthcare, and everybody's enamored with that right now.
Right.
But one of the things I hear our doctors talk about is that every lens is adjustable,
Yep.
okay? Not just the light adjustable
That's
lens.
true. That's true.
Monofocal lens are 100% of patients in monofocal lenses are going to need reading glasses for their reading vision. So they're reading glass adjustable lenses.
Yep.
Okay.
Sure.
And because you're for sure going to be wearing at least readers. And
That's true.
others, so there's glasses adjustable lenses, there's cornea adjustable lenses because a lot of
Mhm.
the multifocals, torics, et cetera, you might have to do a fine tune with the laser. So that's a cornea
Mhm.
or laser adjustable lens. And then there's the light adjustable lens. And it's
Right.
helpful for me to just think about it like that
Yeah.
because every
Th-
patient should know that if they're having cataract surgery, something is going to be adjusted afterwards because there's
Right.
nothing out there yet that does everything all the time,
Yes.
100%.
And if there was 100% lens, Matt, we'd all be using it. We wouldn't even be having this conversation.
That's
Everybody'd
right.
be using it, and we would all know about it. So nothing's as perfect as I would say what God gave you. Nothing's as perfect as when you were 25 years old with your natural lens. But we're getting pretty damn close, and we have some pretty cool technologies that we're very lucky to have in this day and age.
Yeah. Well, I want to ask folks on the line, what questions do we have for Dr. Szabo? Just eager to hear how it can affect our friends across the country here.
You talked about how when patients come in, you're going to play the role of the expert. You're not going to like give them five options and then make them pick.
Hmm.
What's the response rate of patient? Because I operate the same way when I go to a doctor. I'm like, I don't have an opinion. Tell me what to do and I'll do it. What's
Right.
the dichotomy or the dynamic with most of your patients when you're making those,
Yeah.
referrals based on what you think is best for them, do
Hmm.
they typically say, sounds good, let's go? Or what does
Yep.
that typically look like?
I think, Kay, that's a great question. Because you could do whatever as much as you want, as much as, education as you want. And the patient may go the other way, and that's okay. What I try to do, what's really helped me, like I try to gain trust very fast. So, I'm seeing this patient one time before surgery, usually. I really got to establish a connection, establish trust between me and the patient very, very quickly. And the way I do that, like when I go into a room, I already know what the patient's here for. I know exactly what their corneas look like. I know what their history looks like, and I remember their name. So, Kate, if I'm seeing you, I'm going in. Hey, Kate, how you doing, man? My name's Dr. Brian Szabo. I can't wait to. And you have to be enthusiastic with it too. People pick up on your enthusiasm very, very quickly when you're in a one-on-one room with them. And I go in there and I tell them, hey, here's what your eye looks like. Here's what I want to do. And I also try to learn a little bit about them. Hey, what are your likes? What are your dislikes? I ask them, what do they do for work? What's their hobbies? And I kind of make that connection. I'll ask them where they're from. In Florida, everybody's from somewhere else, just like I'm from Pittsburgh. Everybody in Florida's from somewhere else. So I usually start with, hey, Kay, like, where are you from? Like, where'd you move from? And oh, I'm from, Minnesota. Oh, you a big Vikings fan? I try to make a little bit of a connection and find like a common ground very quickly. And then I kind of go into my spiel. You know what I mean? So in terms of how the patients react, it honestly varies so much. And there's different techniques you can use to try to get that conversion and things like that. My thing is, I'm just honest. You know what I mean? I'm just, hey, you're my mom, you're my dad. Here's what I would do, and there's no pressure. You know what I mean? I want to help you. I want what's best for you, and patients can really see that, and you just kind of read the room. Some people are good at that, some people aren't good at that. But you can kind of read the room like, oh, this patient's very interested in this. I should keep going down this road. Or, hey, they're really giving me pushback. I should just say, hey, your surgery's going to go great. We'll take care of it. You know?
Hmm. Yeah, that's good. When I did my LASIK with Dr. Slade, even though I
Yeah.
trusted him exclusively, I did a ton of Googling, like,
Yeah.
how long do I have to wear glasses? How long
Yeah.
does it take to recover? Am I going to feel it? I mean, I just, every question I could
Yeah, of
think of.
course.
Is the
Yeah.
cataract demographic patient similar? Like, do they come in like fully loaded with all of their own kind of
Usually,
opinions?
yeah.
Yeah.
At least in our space here in Tampa, they're very well educated. A lot of their friends have already had it because in Florida, I mean, you have some of the biggest practices in the country. You know what I mean? So they're very well informed when a
Mm.
patient's informed. You know what I mean? Sometimes it's not the right information, but at least there's
Yeah.
there's a starting point as
Mm.
opposed to just saying like introducing something for the first time out of nowhere. You know what I
Mm.
mean? So a lot of times we co-manage a lot too, and a lot of our patients are already told, hey, you have a cataract. But certain practices, you're kind of been seeing the patient as their primary care ophthalmologist for a very time, and then you have to introduce the idea of a cataract. So it varies greatly. But yes, patients are very well informed, even more than they were 5 years ago when I was a resident. You know what I mean? It's changed dramatically.
Is your practice doing anything to pre-educate them before they ever show up, like
Yes.
digitally? Like, what is,
Yeah.
like,
So we
yeah.
we send yeah, it's a great question, Kate. So we send a video. So there's a video of Dr. Newsom explaining what a cataract is. We go into a slight little version of what the lens options are. Not the most detailed version, but in terms of some different options. And hey, your doctor will talk to you about which option is best for you. So we do have like a pre-video that goes out via email and text message, I believe, prior to the vision consult.
That's cool.
Which software are you using to do that? You know,
I'll have to double check that for you, Matt. I don't know. I know our marketing team does it. I will definitely get that information to you, though.
is it Clarity or what used to be OI? Op-
I'm not sure at all. I will
no
get that for
worries.
you. Yeah.
No worries. Yeah, I think there's a lot of people in that space, and I think that they all do a good job. We'll see kind of how things go in the future, but I think an empowered and educated patient is, um, that's where it's at when they
Yep.
show up to your practice ready to go. But that
Exactly.
recommendation, Kate, to your point, nothing's more frustrating than going to a doctor and them laying out your 4 or 5 options. I'm like,
Yeah.
I'm here to talk to you. You're the white coat. You make the
Yes. Yes.
recommendation.
And that's why our practice we keep it at 3 options, right? So there's studies out there that say, yeah, I'm sure Matt, you've seen these marketing and sales case, these sales studies that say anything more than 3 options, you lose the patient.
Mhm.
There's too much ambiguity. So we got A, B, and C. Which one do you want to go with?
Yeah. Well, and that's the initial white paper published by Sears, good, better, best.
Yeah, that's it. That's it.
I always put
Well,
best in the
listen,
middle. I always
yeah,
put
that's
best
right.
in the middle to try to get them to do the one I want. So
Yeah, yeah.
Zabo's probably doing like LOL right in the middle
Well,
option.
I'll kind of say like this is what you deserve.
Yeah.
This is what you owe yourself. If everything were free, you're my dad, you're my mom. Here's what I'm doing.
Yeah,
That's cool.
that's great. The in closing, give us a sense of the price ranges. You don't have to give us the
Yeah.
exact prices, but just give us within a couple $100 of each of those ranges you mentioned. The first one's insurance based.
Yes, first one's insurance based. The second one is like our custom package. So whatever we choose to do, whether that's custom distance only with reader glasses, toric lenses, or whether that's a multifocal or an extended depth of focus lens, I'll just give you the prices. I'm okay with that. It's $4,000 per eye we
Okay.
charge, and
And what
then
about,
and
yep,
then no matter what lens you get, and then the adjustable lens we charge just over about $11,000 per eye.
the light adjustable lens is 11,000 per eye?
Oh, sorry, total. Excuse me.
Yeah.
So yeah, it's like comes to like 5,500 per eye.
Yeah, perfect. Good,
Yep.
good. Good. That's I'm glad because a lot of folks aren't distancing their light adjustable lens price from their multifocal price, and they're doing it because they say, well, multifocality gives me three ranges, and the light adjustable lens kind of does, but maybe not
Yep.
as much near. Like I don't think your consumer cares about those specificities. I think that they care
Yeah.
about the amount of time and the work involved.
Exactly. No, and just the fact that it's adjustable. I mean, nothing else is like that. So, yes, there's more time. Yes, there's more chair time. I mean, you have to make it worth to you and your practice what you think it's worth. You know what I mean? So I see so many patients, so many doctors around the country who charge too little, and they're like, "Oh, this is so much work. I don't want to do this." Well, charge what you think the work is worth, and then you won't have that complaint about the process. The other thing too is, you could put any kind of value on these. This is vision. I can't stand that when doctors just discredit ourselves. You know what I mean? We're giving people the aspect of vision for the next 25, 30, 40 years of your life. I mean, you have dentists charging more than we do. There's plastic surgeons charging more than we do. We do such a bad job as ophthalmologists thinking that what we do matters in a monetary aspect. You know what I mean? Like we are giving somebody vision for the rest of their lives. They are looking out of this lens every second of every day for the rest of their life. Charge whatever you think that value is.
Yeah, and what we know is that in this category, even though it's been around for 20 years, this kind of premium category in cataract surgery is the price is still inelastic, meaning as we change price, it has nothing or less to do with what adoption is like. That's what I
Mhm.
always get confused between elasticity and inelasticity, but it's not tied to adoption. And
Right.
so we found in practices that we work with that as price increases, so does demand.
Yep.
I think it's because team members say, gee whiz, we're charging $1,000 more per eye. We better know what to say. Like we better
Yep.
dial it in and cross our T's and dot our I's. And because they
Mhm.
perform better, their adoption goes up. Because they're more confident in it and they're geared up for it, their
Yep.
adoption goes up. And I just think that there's a lot to that.
Yep. Yep. You could, I mean, just like anything, you could charge whatever you want. You need to show value
Mm,
as the doctor, as the staff, as the coordinators. You need to show what the value of that technology is.
yeah.
You know,
I've always
and
been
so
enamored with the folks who say no to LASIK in the daytime when they come to see us in South Dakota.
yeah,
And then I see them that night at Costco buying a $4,000 framed Samsung
yeah,
TV
yeah,
that
yeah.
that they're going to look through their janky vision
Right.
it's like
Yeah.
I think you missed the point.
Yeah, yeah, yeah. Well,
So
a lot of people, as you know, in our country, think like, oh, if I have insurance, I shouldn't have to pay for anything else. And it's like, yeah, I wish that were the case, but our insurance only covers the standard lens. And literally taking the cataract out, putting a standard lens in does nothing for correction to get you out of glasses. So
yeah,
if you want that extra, you want to see great without glasses, distance and near, it does cost a little money. It's a lot more work for me and a lot more work for the staff. And so you really have to, and patients expect that outcome now. You know what I mean? Like 20 years ago, patients wanted their cataracts out. We were doing cataracts in the 80s and the 90-year-old ranges. Now we're doing
yeah.
cataract surgeries and working individuals that are in their 50s. There's an expectation. I need to deliver that expectation. My practice needs to deliver that expectation. So, yes, there's a value to that.
I like that, and it's easy to get behind you when you talk like that. I can tell, I can feel your passion. And let's not forget, in this category, unlike LASIK, insurance does it covers about a couple $1,000s of it actually.
Yes.
And
Yes. I would
so
say, yes, somewhere between $4,000 and $5,000 with anesthesia and things like that. Yes.
Yep, that's right. That's probably a better way to say it because if they've got a coinsurance deductible, copay situation and
Yep.
it's January 10th and they've got a $5,000 deductible, they're paying every bit of 5 grand
Yes. Yep.
before the 5,500. So,
Mhm.
Brian, listen, we
Matt,
can keep going and
Matt,
going.
I
Go,
got one
yeah,
more thing. Dr.
yeah,
Szabo,
please do.
Yeah,
I was
Kate.
at dinner with Matt and Aspen, and he was with a lens manufacturer that I'll leave unnamed.
Yeah.
And they said what he's talking about is cataracts and all this stuff.
Mhm.
And they asked, what lens are you going with? And he wouldn't
Yeah.
answer. So
Oh, just
I think it would be
God, that
appropriate
looks so good.
for you to nail him down and get
Yeah.
him to admit what lens he's gonna go with.
For Matt? Matt,
Yeah,
for
yeah.
okay, so Matt, what do you, I mean, I kind of know what he's thinking, but what do you right now? I mean, the biggest thing is where do you wear glasses right now just for reading?
I wear them right now. I've had to change the power about every 6 months because of the degradation of my vision, but I've never worn glasses before.
Okay,
Up,
just for
up
reading though.
until up until 2 years ago. Yep.
Just for reading. Yeah. So I mean, so what are you thinking, Matt?
I'm thinking I'm gonna want to go back to being spectacle free.
Yeah. Yeah. So yeah, there's many ways to deal. We're very lucky to be able to have that choice. So I mean, but the thing is, it's very hard, Cade, because I don't know what his topographies look like. I don't know what his retina looks like. There's all these factors that we need to screen for before I can give my expert recommendation. Like, hey, Matt, you're my brother. We're going like this.
Yeah. What I would just do if I were you, Brian, is I would say, what kind of vision does Brad Pitt have?
Yeah.
That's probably what Matt has.
That's what it is. Yeah. Yeah. I
Yeah.
like that. I like that.
Oh, listen, thanks for spending some time with us. This
Yeah.
this conversation is going to be really helpful for folks. I think especially doctors. You did a lot in there about talk tracks and how you say things
Mhm.
to patients that I think is really going to be valuable. So thanks for joining our session today, and we look forward to talking to you again in the future.
All
Thanks
right.
everybody
Thank
for
you, Matt.
joining.
Thank you guys so much for having me. I really appreciate it.